Hello and welcome to this learning module. Today we will discuss the assessment and management of patients who are experiencing a cardiac emergency. This video is intended to supplement any readings or coursework assigned by your instructor. Upon successful completion of this learning module, students will be better able to, number one, complete a cardiac assessment on a patient, number two, discuss common cardiac diseases the EMT may encounter, and number three, provide emergency care for common cardiac emergencies. The steps for the assessment of a possible cardiac patient are the same as for any other patient. Scene size up reminds us to consider things like scene safety, donning proper PPE, the nature of the illness, and the need for additional resources. The primary assessment includes determining the patient's level of consciousness and evaluating and managing life threats to airway, breathing, and circulation. After this, we need to consider whether this patient is a load and go or a stay and play. If we are transporting with a paramedic unit, we may transport the patient to a cardiac specialty care facility. If an advanced life support unit is not available and we are transporting BLS only, we need to go to the closest available emergency department. When obtaining a patient history, the time of onset is extremely important because the management of acute coronary syndromes is extremely time sensitive. Obtaining a detailed history of the present illness or OPQ-RST history is also important. When obtaining the patient's medical history or ample history, remember to ask whether there is a family history of cardiac disease. Cardiovascular disease has strong genetic ties. When completing a secondary assessment on a conscious patient you believe is experiencing a cardiac emergency, we want to be sure to recheck their skin color, temperature, and condition. Many patients experiencing a cardiac emergency will present with pale, cool, and moist skin. Checking DCAP BTLS of the chest area reminds us to look for any type of injury that could be causing the patient's symptoms. As we will learn later in this module, jugular vein distension and swelling to the feet and ankle area would indicate the patient is experiencing congestive heart failure. Assessing breath sounds may also indicate fluid in the lungs, which would be another sign of congestive heart failure or possibly cardiogenic shock. When evaluating chest pain, be sure to check whether the pain worsens or can be reproduced when the patient extends their arms above their head, takes a deep breath, or when you palpate their chest area. Lastly, many cardiac patients will complain of nausea with or without vomiting and a feeling of being sweaty. If these are not present, we want to make note of this because it is considered a pertinent negative in our patient care narrative. Cardiac patients should be monitored very closely and reassessed at least every 5 minutes during transport. Arteriosclerosis is a condition that causes a thickening of the arteries. They become stiff and less elastic, a process that is often referred to as hardening of the arteries. Atherosclerosis refers to the buildup of fats, cholesterol, and other substances in and on the arterial walls that are collectively known as plaque. Plaque deposits can restrict blood flow in the heart and elsewhere in the body as well. Plaque deposits can rupture, triggering the formation of a blood clot or arterial thrombus. Part of the thrombus can break off and become an arterial embolism. An arterial thrombus or embolism can cause a heart attack or stroke. Coronary artery disease occurs when atherosclerosis develops in the arteries that supply the heart with fresh oxygenated blood. Coronary artery disease is the most common type of heart disease in the United States. It is sometimes called coronary heart disease or ischemic heart disease. Acute coronary syndrome is a term used to describe a range of conditions associated with sudden reduced blood flow to the heart. Next, we will discuss acute myocardial infarction and angina pectoris, which fall into the acute coronary syndrome category. An acute myocardial infarction, or AMI, typically occurs when a plaque deposit ruptures and forms a clot or thrombus within a coronary artery. Within 20 to 30 minutes of a reduction in coronary artery perfusion, heart muscle will begin to die. The resulting tissue damage or ischemia may lead to cardiac rhythm disturbances called dysrhythmias and/or sudden cardiac death. Acute MI is what the lay public will call a heart attack. Prompt recognition, treatment, and transport to an appropriate facility is key to providing your patient with the opportunity for a good outcome. Signs and symptoms of a heart attack include a sudden onset of chest pain that is often described as a crushing or squeezing sensation located in the center or the left side of the patient's chest. The patient may also complain of pain that radiates to the lower jaw, left arm, back, neck, or the epigastric area in the upper abdomen. The patient may also complain of a sudden onset of weakness, nausea, vomiting, and diaphoresis. The patient can also present with shortness of breath and may present with an irregular heartbeat. Obtaining an OPQRST assessment is an extremely important component of our assessment. There are treatments available to restore myocardial perfusion, but these treatments are very time sensitive. It's important to obtain an accurate time for the onset of your patient's symptoms. Most emergency departments in the United States can administer a thrombolytic medication that will break down the clots and restore blood flow to the heart. These treatments are not without risk, however, and can cause a stroke and life-threatening internal bleeding as a side effect. If you are able to transport your patient to a cardiac specialty center, they can perform a catheterization procedure that extends a catheter into the blockage to manually remove the blockage and leave a stent or more small structure in its place to prevent further blockage. It's important to understand that patients who have diabetes, elderly patients, and postmenopausal women will generally present atypically when they're having an acute myocardial infarct. These patients may not experience the chest pain that normally comes with an MI. They may only present with vague symptoms such as dyspnea, nausea, lightheadedness, or weakness. Emergency medical care for an acute myocardial infarction includes maintaining an open airway with adequate ventilation and administration of supplemental oxygen to an oxygen saturation of 94%. Unless it is contraindicated, the patient should chew 2 to 4 baby aspirin tablets. If the patient is prescribed nitroglycerin, you can administer 1 tablet or spray sublingually every 5 minutes if their blood pressure remains above 100 millimeters of mercury systolic. The maximum dose is 3 tablets or sprays. An advanced life support unit should be dispatched to all cardiac emergencies. Remember that nitroglycerin can drop a patient's blood pressure considerably, so we must have a full set of accurate vitals prior to administering this medication. Nitroglycerin should not be administered to any patient who has used erectile dysfunction medications within the past 24 to 36 hours due to potential severe hypotension. If there's any question about this, please contact online medical control. Angina pectoris literally translates to chest pain. Angina is a disorder that results from a reduction in oxygen being delivered to the heart muscle because of atherosclerosis in the coronary arteries. The heart's need for oxygen exceeds the available supply due to the narrowed vessel diameter. The chest pain that results is the heart's way of letting us know, hey, I'm not getting enough oxygen down here. Angina attacks, as they are often called, will occur from physical or emotional stress. An angina attack is usually relieved when the patient rests and/or takes some nitroglycerin. The typical angina attack does not usually exceed 10 minutes. In fact, if it does exceed 10 minutes or 3 nitroglycerin tablets, the patient has usually been instructed by their cardiologist to call 911. The term unstable angina implies discomfort that presents with a change in pattern. This means that the onset, frequency, duration, or quality of the discomfort is different from what the patient will usually experience. Unstable angina can occur when the patient is at rest and may last greater than 20 minutes. Additionally, unstable angina is not always relieved by rest, nitroglycerin, or supplemental oxygen. Patients who are experiencing an unstable angina attack will be treated as if they are having a myocardial infarction. Care for a patient we suspect is having an angina attack is to evaluate and manage their airway and breathing. Supplemental oxygen should be administered to maintain a saturation of at least 94%. The patient should take their nitroglycerin as prescribed as long as their blood pressure remains above 100 millimeters systolic. Additionally, consider the administration of 2 to 4 chewable baby aspirin tablets. ALS transport is appropriate for all angina calls. With left ventricular heart failure, the blood backs up from the left ventricle through the left atrium and into the lungs. The pulmonary capillaries leak fluid, resulting in pulmonary edema and impaired gas exchange. With left ventricular failure, you will usually hear rales or wet crackles in the patient's lungs. With right ventricular heart failure, the blood backs up through the right atrium and into the body. Patients with right ventricular failure will usually present with jugular vein distension or JVD, ascites or fluid in the abdomen, and peripheral edema in the hands and or feet and ankles. A patient who presents with both left and right ventricular heart failure would have a combination of all of these signs and symptoms. Congestive heart failure can result from problems with the patient's heart valves, can happen after a heart attack, or as a result of a pulmonary embolism, and resulting from certain cardiac rhythm disturbances. CHF patients will usually complain of difficulty breathing with or without exertion, tachycardia, orthopnea or worsening of dyspnea when they lay flat, tachypnea or rapid breathing, and diaphoresis. They may also complain of chest discomfort, anxiety, and may appear extremely tired if they've been struggling with this for an extended period. Image A shows a patient with jugular vein distension or JVD, which is a sign of right-sided heart failure. Image B shows a patient with lower leg swelling called pedal edema. If you take your index finger and push down in the edematous portion of the patient's extremity, you will notice it leaves a pit that can take up to several seconds for the skin to rebound. This is known as pitting edema. The patient seen in this picture will be described as having 3+ pitting edema. Emergency medical care for a patient in congestive heart failure includes positioning them in an upright position on the stretcher, administering supplemental oxygen to a saturation of 94% or better, assisting ventilations with a bag mask device if the patient is too tired to continue on their own, application of continuous positive airway pressure or CPAP connected to high flow oxygen, and advanced care from a paramedic unit. Hypertension is commonly defined as a systolic blood pressure greater than 160 and or a diastolic blood pressure greater than 94. Common symptoms of a hypertensive crisis include a sudden onset of a severe headache, a strong and bounding pulse, and tinnitus or ringing in the ears. A patient experiencing a hypertensive crisis may also present with complaints of nausea and vomiting, dizziness, and a nosebleed that is difficult to control. Prolonged hypertension can lead to stroke and aortic aneurysm. The medical abbreviation for hypertension is HTN in all caps. Treatment for a patient with hypertensive crisis includes administration of supplemental oxygen, placing them in a position of comfort, and ALS transport to the hospital. At no time should we attempt to administer any medication that will lower the patient's blood pressure. If this is required, it will be done by the paramedic team or once the patient is transferred to the care of the hospital staff. An aortic aneurysm occurs when a weakened section of aortic wall is damaged by atherosclerosis and it begins to dilate or balloon outward from the pressure exerted by the blood that's flowing through it. When this occurs, it's very similar to the blowout of a car tire. An aneurysm can exist for a long time with no signs or symptoms that the patient's aware of, but if it suddenly ruptures, it can cause rapid and fatal internal bleeding. In this image here, figure A shows the thoracic and abdominal sections of a normal aorta. Figure B shows a thoracic aneurysm that would be located behind the heart, and figure C shows an abdominal aortic aneurysm, or AAA. An aortic dissection occurs when blood enters a tear in the inner lining of the aorta, which causes a separation in the layers of the aortic wall. Aortic dissections occur most commonly in the thoracic portion of the aorta. When this occurs, the patient usually presents with sharp pain that is sometimes described as either a tearing sensation or a ripping pain in their chest. Patients who suffer an aortic aneurysm are typically middle-aged and older men who have chronic hypertension. They usually complain of a sudden onset of chest or abdominal pain, and you may notice a difference in the blood pressure between their left and right arms. Additionally, you may see an abdominal mass pulsating in the center of their abdomen, usually just below the level of the umbilicus. You may also palpate this pulsatile mass during your hands-on abdominal assessment. A suspected aortic aneurysm is a potential life-threatening condition that requires immediate surgical intervention. This is a load-and-go situation that requires a medic unit for transport. The EMT should administer supplemental oxygen and should withhold the administration of aspirin and nitroglycerin. Transport should be to a regional trauma center or other hospital capable of immediate surgical care. If the aneurysm ruptures and the patient progresses into cardiac arrest, CPR and application of an AED should be initiated. Myocardial infarction and other cardiac emergencies are not frequently seen in pediatric patients. Pediatric cardiac emergencies are usually due to congenital heart conditions that have been present since birth. As we know from CPR training, cardiac arrest in the pediatric patient is frequently due to airway compromise or respiratory failure. Acute coronary syndrome, such as heart attack and angina, are commonly seen in the elderly population. Remember that elderly patients, as well as patients with diabetes and postmenopausal women, are at risk for atypical presentation when it comes to cardiac emergencies. Some of these patients may only complain of not feeling well, but are having an actual myocardial infarction. This would be called a silent MI. This brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you struggled with. Thank you for watching this learning module.